Welcome all to this closing session, the last session of the COVID-19 in the Americas conference that has been lasting for the last 6 months now. And we are really excited to be on this part and also to highlight some of the outcomes of this conference. So we will have initially some short video messages from some of the relevant participants during the conference. So the first one will be Dr. Julio Frank, president of the University of Miami. The second one will be Dr. Nora Volkov, who is the director of the National Institute on Drug Abuse of the United States. And finally, Michael Weinstein, the president of the AIDS Healthcare Foundation. Later on, I will do a short presentation on the status of the COVID-19 in the Americas, the situation, the epidemiological situation, and some of the relevant aspects of the conference during these last months. And then I'll be back to introduce our two key panelists, and I will do that later. So right now, we can go to the videos, if we can play them now, please.
The subtitle of this conference, Rethinking Everything, is prescient when it comes to global health security. We have learned many lessons over the past year, one of which is that global problems require global solutions. In the present situation, there is a risk of backlash against globalization, but such a reaction would be self-defeating. We are seeing amazing collaboration among researchers in the fight against COVID-19. Global action, however, requires more than like-minded individuals working together. It requires strong global governance supported by national governments committed to international collective action in order to face common threats. A lot has been and is being discussed about the imperative of reforming the institutional architecture of global governance. Among many constructive proposals, there are three innovations that, if implemented effectively, may make the world safer and better prepared for the next pandemic. The first innovation is platforms that are ready-made, which will allow the scientific community to move swiftly in developing the tools to combat disease. A second element is a rapid deployment force with the standing capacity to implement those tools so that future outbreaks may be controlled before they spread globally. And finally, the third key innovation is to develop the legal and institutional frameworks that will enable the effective enforcement of the international health regulations through both sanctions and incentives, such as the ones used by the World Trade Organization and other institutions. This demands a new global health convention or treaty, a new global social contract that redefines the rules and norms of global governance for health security. We have no time to lose. Together, we can strengthen our capacity for responding to and ideally preventing future health emergencies.
The analysis over the period of the COVID pandemic has shown that, unfortunately, the use of substances has increased in the United States, and there has also been an increase in mortality associated with it, due predominantly to overdoses. But we have also seen that individuals that have a substance use disorder, whether it is legal, like tobacco smoking or alcohol, or illegal, like opioids or cocaine or methamphetamine, are at a significantly higher risk of becoming infected. And if they become infected, they're also at a significantly higher risk of mortality, highlighting individuals with substance use disorder as a vulnerability population that deserves attention, both for prevention measures as well as vaccination.
Hello, everyone. I want to congratulate the people who've convened the COVID in the Americas conference over these last 6 months for the great work they've done and the enlightenment they brought to the issue. During these very, very difficult times, particularly in Latin America, we need to start rethinking at every level how we handle global public health. And that's why we've initiated the idea of a global public health convention. And it rests on three very basic fundamentals, which are transparency. Countries of the world need to reveal what's going on as soon as possible. We need accountability so that we have the ability to go in and to root out the problems and address the issues. And we need cooperation. And that means that the entire world community needs to come together to deal with this issue rather than dealing with it on a national basis. If all of that comes to pass, we have the possibility of either preventing or limiting the damage from pandemics in the future. So I want to thank you for your participation in this effort, and please join us in our continuing efforts to make this a world that's much safer from public health threats.
You're on mute, Jorge.
Oh, sorry, I was on mute. So I hope you enjoyed the short videos. They are really interesting ones with very concrete messages from the three relevant members of this conference that were also speakers in different panels. So right now I'm going to share with you some of slides on the situation right now of the COVID-19 in the Americas. And this was mainly the reason why we decided to start in partnership with the Institute of Advanced Study of the Americas from the University of Miami, IAPAC, and the AHF Institute of Global Public Health at the University of Miami too. So because of the situation of COVID-19 in the Americas. So right now I'm going to share with you some slides. I don't know if you can see them right now on your screen. Can you, Caitlin, can you confirm me? No? Yeah. Okay, and the subtitle of the conference is Rethinking Everything, and actually we touched almost everything that's being touched by the COVID-19 pandemic. So right now, the situation as today, this is the growth of the epidemic in the Americas right now, more than 59 million cases. In terms of daily incidence of this, the peak was just last January, the 7th. It was a peak of new cases, more than 400,000 cases in just one day in the Americas. So that was quite scary. Right now it's going down, but it's likely that we will have another wave soon. Well, it depends on the effectiveness of the vaccines and the rapidness of getting more people and more people vaccinated. So we hope we won't get that big wave, although nobody really knows for sure. What is the situation compared to other regions? In the Americas, we have 58 million cases, as I already mentioned it, and that means 43% of all cases in the world. Then the next one is Europe, and the third one is Asia. Something happened here in the graph that is showing like Asia 35%. It's actually Europe, the second largest affected region after the Americas. But in terms of deaths, it's even bigger. The Americas share is 48% of the deaths. Europe is 35%, Southeast Asia 8%, Eastern Mediterranean 6%, Africa 3%, and Western Pacific, that includes China, wherever things started, is just 1%. So they have been really successful in controlling the pandemic there with probably completely different measures that we cannot do here in the Americas. And then when you look at the Americas separated from the rest of the world, still the US has the most cases. Latin America has 45% of them. But when you go to the deaths, the picture is a little bit different because Latin America concentrates almost 60% of all deaths in this region, and the USA is 39%. Canada is just 2%. But also it depends. I mean, it has to do with the size of the country, the population of the country. So Rethinking Everything, COVID-19 in the Americas was a multinational online conference that aimed to address the historical challenges presented by COVID-19 pandemic. And the objective is, it was to rethink everything, the management of the pandemic through meaningful dialogue between experts, activists, and professionals from throughout our continent. Statistics of participants. We had 40 panels. 21 of them were in Spanish, 15 of them in English, and 4 panels in Portuguese as well. We had 159 panelists from 22 different countries. We transmitted in 3 different languages, and a wide range of professional representatives from activists, the medical doctors, social workers, nurses, lawyers, prosecutors, politicians, health ministers, etc. So this is kind of a profile of all the flyers that we were distributing in terms of the panels that were in Spanish and in English. And these ones are mainly the ones in English and Portuguese as well. I think I presented first the English and Portuguese, and second one are the ones in Spanish. So a little bit more than half of them were in Spanish and the rest English or Portuguese. So 22 countries represented in conference panels, almost all Latin America, from Argentina to Venezuela. So they are listed here. The speakers came from those countries. So it was very successful in terms of reaching out to multiple participants through the whole Americas, the entire continent. Weekly themes, it ranges from a wide variety of them, like from sexuality on COVID-19, don't forget about HIV, women's health during the pandemic, palliative care, the role of governments, of myths and facts, the 2 roles, social justice, health equality, lurking beneath the surface, and substance use disorder, mental health, the economy, cultural ethos and pandemic in the Americas, March for a Better Future, and multilateral agencies and global health security as well were addressed during the conference. Some renewed participants included the president of IHF, the president of the University of Miami, the director of the PAHO, the Pan American Health Organization, the director of the National Institute of Drug Abuse, a deputy minister of multilateral affairs from Mexico, the vice minister of international economic relations of Chile, an advisor to the president of Argentina, the president of Human Rights Campaign, and many other relevants, including the ones that will be speaking after me, Dr. José Zuniga and Dr. Felicia Knaul. They were also part of the panelists during this conference. So the delegates statistics in terms of the people attending. So we were not just having attendance from the Americas. We also covered some other countries that were interested on listening to our panels. So it was almost 1,580 on the current platform. But then we also reached through social media as well. The gender balance or the correlation, it was 58%, women, 37% male, and some others of non-binary or prefer not to say. So the country representation, actually, we reached 71 countries. That means 29% of the countries of the world in the 5 continents. We have 29 panels streamed via Facebook Live, and also AHF accounts in Latin America and the Caribbean. So the total people reached during these 6 months through the conference was 27,000, a little bit more than 27,000 people reached. So we have also special collaborations from podcast, also organized through podcast, which is a kind of different platform. So we had some highlights like don't forget about the HIV/AIDS. HIV was already forgotten before COVID-19, And on UNH report for World AIDS indicated that every single one of the 10 major targets set up in 2016 that were supposed to be achieved by 2020 failed. That means the objectives of controlling HIV failed because of this pandemic. That was said by Stephen Lewis. There were some other highlights, but other members of different panels, I just, in order for the sake of time, I'm just going to highlight the first one, but there were many highlights during the conference on different panels of different speakers and different specialists. So on myths and facts, we also had some interesting points. There is a huge lack of science-based journalism on health issues. That was said by Nora Barr. Is a journalist, a very well-known journalist in Argentina. Misinformation kills. That was said by someone from Panama. The immediacy of access to information and control government communications contributes to misinformation in the countries. That was said also from someone from Panama. So there were many messages, interesting messages, and also notes that we really like to highlight, like the importance of collaboration between countries must be emphasized since no one saves himself. This is a global pandemic, was said by Cecilia Nicolini, who's a close advisor to President Fernandez from Argentina. Another quote, we have witnesses a clear discrimination phenomenon due to the fact that the countries that do not have access to vaccine are precisely the countries with the lowest economic incomes. That was said by Vice Minister of Foreign Affairs, Marta Delgado from Mexico. And also we should ramp up regional vaccine and drug production capacity in order to achieve the desired self-sufficiency in health issues. That was said by Efraín Guadarrama, who is the coordinator of the Caribbean the coalition of Caribbean and Latin American states. So the organizing entities of this conference, of course, I mentioned it, it was the Institute of Advanced Study of the Americas from the University of Miami, the International Association of Providers of AIDS Care, IAPAC, and of course the AHF Global Public Health Institute at the University of Miami. So we had what we call radical cooperation because there were many people involved, and we want to thank all of them. So I have here the names of each one of them. I'm not going to read them, but yes, I wanted to really highlight their names also from their different task teams, also at the AHF Global Public Health Institute, from AHF Latin America and the Caribbean, and AHF Global. So we were many of us involved to make this thing happen. So I will stop sharing now my screen, and then I will go to the presentation of the two speakers for today. And the first one, it is Dr. Felicia Marie Knaul, is the director of the Institute of Advanced Study of the Americas and professor at the Miller School of Medicine at the University of Miami. She's also a senior economist at the Mexican Health Foundation and founding president of Tómate Lo Pecho, a Mexico-based NGO focused on research, training, and advocacy around women's health issues in Latin America. Dr. Knaul has created and coordinated many international research and advocacy networks. She currently co-chairs the Lancet Commission on Gender-Based Violence and Maltreatment of Young People. From 2014 to 2017, she founded and chaired the Lancet Commission on Global Access to Palliative Care and Pain Relief. And from 2012 to 2015, she was a member of the Lancet Commission on Women and Health and a leading co-author of the June 2015 report. She has held senior federal positions at the Ministries of Education and Social Development of Mexico and at the Colombian Department of Planning, and work on health reform and social development in both countries. Dr. Knaul has also worked as a consultant and advisor for bilateral, multilateral agencies, including the World Health Organization and the World Bank. Dr. Knaul has approximately 250 academic and health policy publications, and her research focus on global health, female labor force participation as well, medical labor markets, the caring economy, gender equality, violence against women and children, health system financing and reform, cancer care and control, pain relief and palliative care, poverty and inequality, and children in especially difficult circumstances. Dr. Knaul received her BA in International Development from the University of Toronto and a Master of and an MA and PhD in Economics from Harvard University. So I'll leave right now, and it's my pleasure to leave the floor to Dr. Felicia now. Felicia.
Thank you so much, Jorge. It has been such a pleasure for the University of Miami, and especially our University of Miami Institute for Advanced Study of the Americas, to be able to work with you, Jorge. You've put together an incredible set of events. As I said a couple of months ago, I didn't think it was possible to have that many events in such a short period of time, but if anybody was going to pull it off, it was going to be you. And every time there is a crisis in our region and the world, you are the one who stands up and one of those people who does something. So we are so pleased that we were able to collaborate with you, with AHF, and with IAPAC on this. Starting out, I'll just also thank my own team at the Institute for Advanced Study of the Americas, but also those at Tómatelo Pecho, our NGO, that works so diligently to put together the events that I'm going to share with you, particularly Sonia Ortega and Julio Rosado and Hector Ariola. Now, I'll go ahead and share screen and just share some of the richness of the materials that we came through with. And I'll start sort of saying it's a patchwork, but when we sat down and put it all together, we realized what an incredible amount of knowledge had come through in the sessions that we were able to do within this, very important and inspiring title, Rethinking Everything COVID-19 in the Americas. I think it was a brilliant title, is a brilliant title. Leads us right up to this idea of building back in a completely different way. So we did 5 panels in a plenary conference with 24 panelists, and we covered 11 countries and 17 institutions, as Jorge said, from the Americas, and particularly Latin America. And the reason being that we're especially concerned that Latin America is 8% of the world's population, yet as of the beginning of April was contributing more than 40% of the deaths, and somewhere around 30% of cumulative deaths overall. So what that shows that it's way beyond the participation of the region by population, what is happening in terms of this disease. So let me speak to the first panel, which is around the importance of thinking very carefully about the health of women in times of COVID. And our discussants, our presenters highlighted a number of key aspects: sexual and reproductive health services, the lack of access to prenatal checkups, the problem with timely detection and diagnosis of cancer, we'll go to that in a minute, the lack of access to consultation, particularly for those with chronic illnesses and mental health services, and increased needs, for example, gender-based violence, and of course, mental health again, and what that meant. We summarized how we went at this, saying that COVID-19 required a reorientation and a restriction of access to many health services. But that was done without a gender-sensitive or gender-proactive approach or lens. And the conclusion here, I was looking through all the conclusions, but the conclusion is that we have to think always with a gender-sensitive and gender-proactive lens when we are undertaking any health system intervention or social intervention, social sector intervention. And of course, a time of crisis like COVID-19 made this, all the more important. So going forward, the best time to have planted a tree was 20 years ago, but the best time to plant a tree, it wasn't 20 years ago, is today. And I think now is the time to take a very careful look at what has happened and how we can fix it going forward, and keep, really in the front of our mind that we have to always be asking these gender sensitive and gender proactive questions. And so when we turn in the next event that we hosted, which was very specifically around the issue of cancer, women's cancers, what COVID has meant for women's cancers, and we ended up really focusing on the case of Mexico, but I am sure that this is more generalizable. So first, a supply side issue is that there was a decline. Sorry, let's go to the demand side first, actually. The demand side, it's at the bottom. There was a fear of contagion that would make women hesitate and look at postponing treatment and postponing diagnosis or early detection. Going for regular checkups became something, and I can speak for myself as well, as someone who lives with breast cancer, that one just didn't do. So that was the start of the problem. But then on the supply side, and you'll see some of the data in a moment, we had a tremendous decline in the number of cases that we're seeing. And that isn't because there's less breast cancer or less cervical cancer or less, in fact, of any chronic or non-communicable disease. It's that we are not serving our population the way we did even before. So we already had a huge problem of late detection, making these issues much more difficult to manage. We know that in the case of Latin America, for example, we have about 20% of women's breast cancers diagnosed in early stages compared to about 2/3 in the US. So we already started out, we went into this with a major problem, and we've made it much worse. We have a tsunami of late detection that is going to happen on chronic and non-communicable diseases, several of which have to do with women's cancer, and always keeping in mind in the context of the other issues that we just looked at in lack of access for women in particular. And then you dumped on top of that, in specific countries, and here we're using the example of Mexico, the very unfortunate decision to make major health system changes right at the time when a disaster was about to hit. And the analogy that we shared often in these discussions is that you may or may not decide that it's not the roof you wanted on your house, but you don't decide to change your roof during hurricane season. You wait until a point in calm. And so making these, as you'll see in a moment, major health system changes were really sort of the icing on the cake of generating what is going to be and what has been a disaster on the side of chronic and non-communicable diseases. So again, let's look at women's cancer specifically. These are data that Hector Ayola has put together for us. We're comparing the number of women who are diagnosed month by month, in this case for breast and cervical, and men for prostate, comparing 2020 to 2019. And you keep seeing it's a decline. If you look at other diseases, in this case diabetes, you'll also see a major decline, somewhere between 20 and 50%, depending on what category we're looking at. And of course, the only one that increased is anything that is associated with COVID-19. Again, this is not real. Obviously, there isn't a decline in the number of cases. There's a decline in our capacity to diagnose. And then I wanted to highlight a very interesting paper by Cynthia Villarreal and colleagues that came out in the Lancet Oncology a few weeks ago, where she highlights what I was saying, which is that deciding to make a major change in a health system in the face of this pandemic was a very difficult and dangerous thing to do. And in the case of Mexico, we're seeing this play out with the sort of data that she was able to share. 142 patients with breast cancer, 83% of the treatments had been interrupted or modified at some point, and 6% said they had not been able to start any kind of treatment. Right? These are entrenched problems, late detection of non-communicable diseases like women's cancers, and they require innovative solutions. So on the upside, I think what we've seen discussed over and over again in this session and in others is that the chaos and challenge of COVID-19 can in fact generate opportunities, in this case to close breast cancer divides, but overall to give opportunities for a really, a new tomorrow. A year and a half ago, if you had asked me about telemedicine, if you had talked to me about breaking down the barriers that existed between specialist physicians and non-specialist physicians, I would have said we are a long way off. We as a team had been trying to introduce innovations for the last decade with regard to breast cancer. But now we can talk about using telemedicine to harness primary and secondary levels of care for diagnosis and for treatment. We can talk about engaging nurses and health promoters in different ways, for example, clinical exams, and we can talk about new opportunities for training and exchange of knowledge and ideas in real time that cross geographic borders, but also cross professional borders, so that we have specialists speaking with generalists, speaking with others in the health system. Now turn to the next event that we hosted, which was around palliative care and pain relief, with some close colleagues of ours, and I'll highlight in particular Dr. Liliana de Lima, who has really been a force in Latin America and overall globally on the issue of better access to palliative care and pain relief. And many of them had participated in our Lancet Commission work and the analysis of health systems that you're basically seeing there, that is in fact presented in our Lancet report, and that was designed precisely with Dr. Julio Frank, where we thought about, in order to get universal access to palliative care, what did you have to do in addition to all the other things we have to do to look at UHC? And I just highlighted a couple of them. And one of the most important that we said going years back was that you needed to make general competency mandatory, a mandatory component of absolutely all health professional curricula. That was one piece. And overall, that if you didn't do this, there was no way that we were going to be able to achieve universal health coverage or SDG 3, because palliative care and the relief of pain and suffering is an integral component of universal health coverage that's been forgotten. We looked at data like these that showed a tremendous lack of capacity across all low and middle income countries, and clearly also in our region, and in many cases getting worse, like in the case of Mexico, to actually be able to meet even the basic needs for pain relief. A huge problem, a huge equity divide. And we came together as a group and we shared some of these data in the panel that we hosted around how to extend access to palliative care as an immediate response to COVID. And the reason we were saying this is precisely because had the world listened to some of what the palliative care organizations had been saying for a long time, we believe that we would have been able to, for health professionals, to reduce suffering around COVID-19 as well. But again, not too late, quite the opposite. The times continue to be very tough in our region around the world. And so here are some of those conclusions. We have to take advantage of the new and simplified procedures that were offered by the International Narcotics Control Board because of the pandemic, to be able to increase the adequate and legal supply of opioids. We have to conduct rapid training for all medical staff to be able to help them to address palliative care needs, but even more so, I would say, to enable them to deal with what is now on a daily basis death and dying. Most health personnel are not equipped and not trained to do that, but people who do palliative care are. We deal with death and dying on a regular basis, and so there's a lot that can be offered to support all the rest of medical professionals. Engaging technology and technology partners to be able to make it easier, particularly at the community level, to reach out to patients in their home. And mobilize and train volunteers to be able to connect to patients who require social support. And really the key to palliative care and the key overall to healthcare, which is compassion and relief of suffering at a time in COVID when we're seeing so much more on the mental health side and others. And finally, we suggested some longer term strategies, which were around, again, expanding all study plans for all types of health professionals, ranging from doctors to social workers, and including even religious and support staff, to include the basic competencies of palliative care. Again, had we done this, the world would have been in a better place to have been able to meet the challenges of COVID-19. And establish standard and resource stratified palliative care guidelines and protocols for all different stages of the pandemic, based on rapidly evolving situations and scenarios. Then we turn to an overview of our analysis of the specific policies in our region for a series of countries, based on a major project that we've taken on, an observatory at the subnational level, to look particularly at non-pharmaceutical interventions across our region. This is become a very large project that involves a large number of researchers that are named here. I want to make it clear that it really is a group effort, and highlight this because almost all of these individuals and their students are working voluntarily to make sure that these data are available. We're covering Argentina, Bolivia, Brazil, Chile, Colombia, Ecuador, Mexico, and Peru. And I highlight the work of the co-lead on this, who's Professor Mike Tushton. What we're doing with this observatory is that day by day, we're offering the data up to date at the subnational level on population mobility, but even more so on the strategies that countries are adopting, that states are adopting at the national, subnational level on initially non-pharmaceutical interventions, and soon we'll be adding vaccines into that. The information is available at the website, observecovid.miami.edu. But la neta, as we'd say in Spanish, the bottom line is Latin America is one of the regions in the world hardest hit by COVID-19, as Jorge shared with us. Brazil and Mexico are the epicenter of the epicenters. What we're seeing with all of our data is tremendous variation, not only across countries, which have been shown, but within countries on policies to manage COVID-19, and that this variation has almost nothing, if anything at all, to do with evidence. Some of it is political partisanship. Others seems to be literally a random and chaotic response because of the lack in several countries, primarily Mexico and Brazil, of the ability to offer a national coordinated set of guidelines, and also because of lack of use of testing in most countries. Chile, of course, is the exception in our region, as well as Uruguay, but among the countries we studied, Chile is the exception, although Chile is, of course, going through a very difficult time right now. We highlighted that it's really impossible to understand the pandemic using only national level averages. To understand the response in any of our countries, we have to look subnationally. Finally, we had a session around non-communicable diseases with some real leaders in the field, David Watkins, Carlos Santos-Bourgois, and my colleague Rachel Nugent. There were a lot of things discussed there that came out, a very rich session, but overall we spoke about things like building social networks to support health, a shift or expansion of investment in public health capacity at all levels of care, the need to protect people through adequate regulatory actions at local and national level, and how much we lack in terms of an appropriate surveillance system, and how that has sort of caved in the face of COVID-19. Okay, I'll stop there, and let's just go ahead with the rest.
Well, thank you very much, Dr. Knaul. Now it's my pleasure to introduce the head of the other organization that was co-organizing this conference. And actually, they were in charge of most of the technical part of the broadcasting and transmission through different platforms. Dr. José Zuniga is the President and Chief Executive Officer of the International Association of Providers of AIDS Care, IAPAC. Dr. Zuniga was appointed as President of IAPAC in 1999 after having served as IAPAC Vice President for Programs. Charged with advancing the Association of Medical Education and Technical Assistance initiatives. Prior to joining IAPAC, Dr. Zuniga served as Director of Strategic Communications at the AIDS Action Council in Washington, D.C., following his military service in the U.S. Army, including combat during the Persian Gulf War, during the Operation Desert Shield and Desert Storm that earned him a combat medical badge. Dr. Zuniga has earned a Master of Public Health degree in Health Policy and a Doctor of Philosophy in Human Development and Social Policy. He lectures at several academic institutions, has been published in various journals, authored thematic chapters for 4 books, and edited 4 thematic books. The HIV Pandemic by the Oxford University Press in 2006, A Decade of Heart in 2008, Advancing the Human Rights to Health in 2013, and Avoiding AIDS Armageddon in 2019. He's editor emeritus of the Journal of the International Association of Providers of AIDS Care, and he serves on the editorial advisory board of the International Journal of HIV/AIDS Prevention, Education, and Behavioral Science. Dr. Zuniga is an IAPAC trustee, a technical consultant for the Collaborative Institute of Virology, and a member of the Joint United Nations Program on HIV/AIDS, UNAIDS, Scientific and Technical Advisory Committee. He's one of the co-signers of the Paris Declaration on Fast-Track Cities and spread heads of IAPAC efforts as the core technical partner for the Fast-Track Cities initiative. Dr. Zuniga routinely advises United Nations Health Agency, including the WHO and its regional offices, as well as bilateral institutions such as the US President's Emergency Plan for AIDS Relief, PEPFAR. He is a member of the American Public Health Association, the National Hispanic Medical Association, and senior associate member of the Royal Society of Medicine in the United Kingdom. So it's my pleasure to leave the floor to Dr. Zuniga. The floor is yours, Dr. Zuniga.
Thank you very much, and good afternoon to all of you who are joining us for this closing panel. If my staff don't mind putting up my slides, because I don't trust myself in sharing screens. I've had too many mistakes. So first of all, I wish to thank Dr. Saavedra and the AHF Global Public Health Institute, as well as Dr. Felicia Knaul and the Institute for Advanced Study of the Americas for this unique partnership to coordinate the COVID-19 in the Americas conference. I also want to acknowledge a few of those individuals who have helped make the conference possible, including Jonathan Hess and Ray White from my staff, Ariel Garcia and Guillermo Faviero as well. But I would be remiss if I didn't express my gratitude to those thousands of individuals who attended one or more of the 40 plus panels that were coordinated from November 2020 through March 2021. As the last speaker of today's closing panel, I want to share some reflections regarding key takeaway messages from a few of the panels that IAPAC co-hosted throughout the COVID-19 in the Americas conference. And while we covered much ground across multiple domains, what strikes me are the universal themes of action in the face of struggle and equity in the face of so many people left behind. Next slide, please. So today, more than 14 months after WHO declared COVID-19 to be an international public health emergency, our scientific knowledge about COVID-19 has advanced tremendously, and we have vaccines that were developed at an astounding pace, though we must concede these vaccines are being rolled out at a glacial pace in most of the Americas. On the flip side, we have heard from the many experts presenting during the conference that our policies have not seen the same rapid and remarkable advancement. Today, we face a second pandemic, a pandemic of inequities. And this pandemic, if left unaddressed, could persist long after COVID-19 itself has finally been controlled. My goal today is to highlight some of the action items that we heard from speakers throughout the COVID-19 in the Americas conference and synthesize some of the next steps for those of us who work in public health and are concerned with the myriad inequities that we're encountering. Next slide, please. So first, the most glaring inequity that we have yet to address is the profoundly unequal access to COVID-19 vaccines. We hosted a panel entitled A People's Vaccine, where Georgetown University's Professor Larry Gostin noted that ensuring equitable global access to COVID-19 vaccines is, quote, not just a moral imperative, it is also a global health security imperative. If there's one thing we should have learned from this pandemic, it is that public health emergencies do not respect national borders, and yet we are still taking a completely nationalistic approach to attempt to end a global health crisis. Dr. Chris Etienne also joined the panel. She's the director of the Pan American Health Organization, or PAHO, noting that the problem is not so much the capacity to administer the vaccine, which PAHO has been addressing by helping countries plan, prepare facilities, and train workers. The problem is access to actual doses, which have been overwhelmingly bought up by the world's wealthiest nations. She noted that, quote, if we do not have access to vaccines, all of the plans and all of the training will not result in timely control and eventually in stopping transmission. One important facet of the solution is in diversifying research and development and manufacturing capabilities, which could be a game changer, meaning turning on its head the current system that allows countries to produce their own medical and other commodities. The inequitable distribution of commodities must also be addressed to address the geographically skewed rates of vaccination so that we don't see the United States and other countries, rich countries of the world, monopolize the purchase of vaccine commodities. But I'll also mention that preparedness is also key to optimize our readiness for future public health crises. For example, it's clear that the international health regulations governing pandemic preparedness and responses should be enforceable rather than voluntary, which has in part contributed to the loss of life and treasure we've witnessed over the past 14 months. Next slide, please. We also have not addressed the socioeconomic toll of COVID-19 or arrived at consensus about how to consider economic and equity concerns in addressing this or future public health emergencies. Dr. David Wilson of the World Bank noted in his presentation that among economic recessions of the past few decades, this one has been unique because of its disproportionate impact on lower paid jobs and therefore on those people who are mostly economically constrained. He reported that the top quartile of economic earners had already more than recovered from any financial losses they had incurred during the COVID-19 pandemic, while the bottom quartile is still earning 30% less on average than they were 13 months ago. We then asked Professor Sanjay Reddy from the New School for Social Research to explore some solutions, and he posed a basic yet extremely profound question. What should be the goal of policymaking in this area? He proposed governments continue to refine risk mitigation approaches to be as targeted as possible, but also to ensure that the public health and economic policies that are implemented are equitable. Stimulus packages seem to have helped, and so do policies that make it possible for people to take the risk mitigating actions that we needed them to take. For example, why not pay for people who are at risk for COVID-19 to stay home rather than expecting them to choose to lose wages? The economic impacts of the pandemic will be felt for years to come among those people who have lost their jobs or face reductions in their income. And clearly, we cannot leave these individuals behind. And so on the policy front, we must also dispel the myth of public health versus the economy. In an emergency such as the one we have endured for more than 14 months, it is not public health or economics. It is both or neither. Next slide, please. Another key issue we addressed during the conference is related to stigma and marginalization facing people of color, immigrants, and LGBTQ individuals, the latter of which was the focus of a panel that included Alfonso David, president of the Human Rights Campaign, or HRC, here in the US. He noted that LGBT people are being left out of the national narrative in the United States. And we heard similar stories from panelists from Canada and Jamaica during that panel. The almost complete lack of data about sexual orientation and gender identity means that governments can continue to ignore these populations as they often do, as those of us who work in HIV know all too well. Similar problems have been reported around accurately collecting data on race and ethnicity, where we know there are also significant disparities. All people, and especially those who already face the greatest health disparities, should be seen and counted. And we, as a public health community, have an obligation to work now to incorporate sexual orientation, gender identity, and other measures into public health surveillance, so that doing so is the norm and not the exception. We were also reminded during this particular panel about how in times of crisis, the stigma and marginalization faced by LGBTQ people are magnified. For example, in countries that divided shopping days by gender to limit crowds, transgender people could not leave their house without fear of harassment or arrest. And many LGBTQ people lost access to their social networks and safe spaces. Stigma and marginalization must be addressed on a systemic level if we do not want to see them driving health inequities, whether in relation to COVID-19 or HIV or other health concerns. And here I'll quote Jamoki Patrick, director of the Jamaican Network of Seropositives, who put it this way during his remarks, quote, "This is about fighting for recognition and basic human rights, not just a Band-Aid to get us through the pandemic." Next slide, please. Finally, just as we require greater global cooperation to address COVID-19, we also need engagement at the city level or the subnational level, as Dr. Knaul pointed out. That's where the rubber meets the road. City governments and community stakeholders understand their populations and are held accountable by them in a way that is not always true of national actors. As UNA's Deputy Executive Director, Dr. Shannon Hayter, indicated during a panel that was focused on city leadership against COVID-19, quote, "For many cities, COVID-19 is a health crisis, which is aggravating inequalities that matter in people's day-to-day lives." During this panel, Shannon and I discussed the concept of city multilateralism, in which cities are included at the global table on public health. We have now seen how important city governments and community stakeholders are at transmitting and translating public health guidance. And beyond just being an intermediary, we have often seen city governments take the lead where national leaders have failed to act on COVID-19 and other health concerns. Examples abound, whether it's mask mandates, limiting crowd sizes, or engaging in emergency responses. Many cities have led, and not always by default. That is why I noted during that panel that we cannot relegate our urban leaders to the sidelines, but expect them to play a role in public health crises. Whether addressing COVID-19 or HIV or TB or viral hepatitis, national and global actors must actively include city governments and local communities in efforts to adequately and equitably strengthen and manage public health responses. Next slide, please. So to conclude, it took only a few months for our research institutions to expand their knowledge of the virus, and only slightly longer for scientists to develop multiple vaccines for emergency use. But those scientific advancements have not ended the COVID-19 pandemic, and they certainly have not addressed the inequities that are by now extremely well documented. Like the second and third and fourth waves of COVID-19 that many of our nations have endured, these continued inequities are not just bad luck, they are the result of our public policy decisions. So governments must let science drive decision-making, but they must also ensure that their policy decisions have equitable outcomes. They cannot shut down restaurants and stores and not provide a safety net to those employees, just as they cannot open businesses to score political points and tacitly accept that those businesses' workers will pay the price, including possibly losing their lives to COVID-19. Moreover, I would say they cannot claim to be using data to drive decisions when key populations are left out of that data entirely. And they cannot use nationalistic policies to end a global crisis or let national actors ignore local concerns. We cannot end COVID-19 or prepare for future pandemics if we are not willing to address this pandemic of inequities that predated COVID-19, has been placed in stark relief because of COVID-19, and will sadly endure beyond COVID-19, unless all of us who are working to advance equity in public health push relentlessly to change the dynamic in honor of all those men, women, and children whose lives have been claimed by COVID-19. Thank you very much.
Thank you, Dr. Zuniga, and I will leave it to you for the final part. In terms of questions and answers, I think we have like 5 minutes only. I just don't want to stop speaking right now without mentioning how thankful I am to the work done by Ariel Garcia and Guillermo Ferrari, and also Juan Manuel, who were working on this, and of course to the staff from IAPAC, Jonathan, and also from Tomatelo Pecho people who were involved. So I leave it to you because, and also sorry information, sorry, and many others. So I will stop here anyway. Otherwise, I will forget some names. Jose, I'll leave it to you now.
Thank you very much. I know that Dr. Knaul has to leave us sharply, I think at 3. So I will direct one of the questions that came in through Facebook for you from Miriam Ruiz. What would you say to people who are scared to go for preventative actions these days? PAP, mammograms, HIV testing.
And Jose, just before I do that, I want to say what a wonderful presentation, and the caring and the concern and thinking of the loss of human life and the people who are suffering was just exactly where we have to keep this in mind. Just as we're going through this, a colleague of mine was texting from Canada about, someone dying in hospital. So we are seeing this still playing out in all kinds of ways in most countries around the world. Just the US seems to be sort of an exception, and it's a very inequitable feeling now to have access to vaccines when others don't. I saw that question coming up again. We should feel very uncomfortable about that. It's the right thing to do. Very upset and very uncomfortable about having access when others don't. But we're arguing about COVID-19, but I could have said the exact same thing about treatment for breast cancer. I should feel, and I did when I was being treated, very, very upset that the person across the street, the woman my same age, same children, wasn't going to have access to the same treatment. The right thing to do is to do something about that. Now, that's what sort of we can do. But I think that question asks, what can the individual do? And yes, there's fear. Yes, there's concern. And it was always hard to get access to appropriate diagnosis and early detection. So that hasn't changed. And so it's up to our civil society organizations to continue to fight for that access, right, so that it's there. It's also the right time to, with all of the care in place that one has to have, the use of masks, making sure that you're going to a reputable facility, to be able to do the early detection that will make a difference in access to treatment. All of that said, we were on a breast cancer event yesterday with UHealth, and a colleague of mine sort of said to me, we realize you're a year late with your mammogram. This is what is going to happen. So I think the bottom line is, yes, you have to have the courage to risk it, to go forward if there's access in a safe environment. And we have to continue to advocate, scream, and yell the way we did before COVID, during COVID, and after COVID, for increased access to the services that are going to save lives. And I'll just say one other thing, which is that I'm a huge advocate of early diagnosis, appropriate early detection, timely detection, but it isn't enough to know you have breast cancer. You have to be able to treat it if you have it. Right? So we need three things: increased awareness, earlier detection, and access to appropriate treatment. And again, to say, we have to be hopeful. It isn't the right message to say, don't find out you have it because you can't get access to treatment, because there are ways, and we have to continue to fight for it. So that's where I would I would leave it on that question.
Thank you very much. Jorge, we have a question about what are the expectations of the third wave approaching in the region? Have we learned from previous contagion peaks?
Yeah, it looks like, yes, we are learning. In terms of treatment, we are learning. We are just on a different project analyzing the data, especially the data from Latin America. It looks like we are learning. I can say better. The doctors providing care, the healthcare personnel in hospitals, they are learning. They are the ones learning, actually. But it will depend mainly on two things the way I see it. One is the rate of vaccination and the proportion of people that have access to vaccine and have been vaccinated. And the second one on the mutants, or the genomic variants that are there now spreading, especially in Brazil. So that can affect the third wave as well. So it looks like, looks on one way it will be the learning curve, but on the other ways, the variants, the new variants that can affect or not the efficacy of some of the vaccines. So that will depend on, that will be the one that is shaping the new third wave.
Okay, I will pose the next question to the two of you very quickly, and then I'll take the last one if you don't mind. So the next question is, what message would you leave to decision makers in the Americas region about the lessons they have failed to learn during this first year of the pandemic? Whoever wishes to start.
Knaul first. Felicia? You are on mute.
You're saying, Jorge, you go ahead first. I'm okay for another.
Okay, thanks. Well, I would say that I say that the healthcare personnel are learning, and we can see that on the death rates coming from hospitals. So they are dying less because they are learning better ways to treat patients. And some people, they know how to care about themselves as well, when to go to the hospital, when they can get some care at home. But the second one is politicians and decision makers. Some of them clearly are not learning even after they got COVID-19, especially some presidents in Latin America. I will say the country that's most difficult to learn from the highest levels, I will say, is Brazil. Uh, the head of the government there is not learning anything. There are some others in other countries as well, like Mexico, but probably is not as radical as what is the situation right now in Brazil. I will say that some of the decision makers looks like they are not learning fast enough. Some of them, yes, they are learning. So some of them, like in the case of Chile, I'm impressed on the rate of the vaccination. Like they are really speeding up the process of vaccination, the Chilean population there. So yeah, they need to learn still.
Well, I would add, I'm not sure. I think it's a close race between the Brazilian and the Mexican president as to who is saying the least evidence-based message in any given day or hour, actually. Neither have, and they're not the only populist leaders who did this. Neither of them, or rather both of them, have chosen to base the vast majority of their comments on, I would say, personal preference or political positioning, rather than on the evidence that we have in the world. So what is the lesson there? I think there are a couple. One is we talk about being evidence-based for a reason, right? We talk about using the science at hand for a reason. And I think the whole idea of flattening the curve in COVID-19 wasn't that we thought people wouldn't die. It was that we were trying to buy enough time to have science catch up and give us better information on how to manage this from a public health point of view, and also in terms of treatment. So you get that science, use that science once it's there. It's a luxury to have it. At the beginning of the pandemic, we had so little. Now we have quite a bit more. So not to use it is I think is sinful. What other lessons? I continue to harp on this idea of the role of subnational governments. Either because what we're thinking about is punt politicking in some places, or others just because the reality is that this is such a crisis that many subnational governments have had to take on roles that they never had to take on before, but they also don't have the same access to the evidence, to the financing platforms, to our regional and global institutions. This has always been a relationship between national governments and regional or global institutions. So I think we have to think about how to support subnational leaders, state level secretaries and governors, not only within their countries, but as individuals as they're trying to learn how to manage this pandemic. And that, multiplies the work by 32 in Mexico and 27 in Brazil. It multiplies a lot, but I think that's the reality of what we're seeing. And in many of these states, we're talking about populations that are as large as several of the countries in our region. I can't but go back to some of those comments about palliative care and pain relief. What did we knew that we needed to prepare all of our health personnel to be able to manage death and dying. We just didn't realize when it would hit. Right? But it did. And they're basically unprepared to deal on a daily basis with losing patients at this level. And we've seen how that's played out. So, there is a science, there is a knowledge of how better to manage this. We should use it. We should access it. We should get that kind of help and support to our, frontline workers. And I bet I'm not telling you, Jose, anything you don't know having served in the military, right? That how do you prepare people like that? You can't properly do it, but you at least can offer information, support, and the evidence and knowledge we have to assist in that. And I don't think we were prepared.
Thank you. So I propose that we each respond to the last question before I turn it back over to Jorge to close the panel. And this question is around vaccine. The distribution of vaccines in the region is not being done on the basis of equity. The countries that can pay for them are the ones that are monopolizing the available doses in the market. What can civil society do to demand a universal right to this common good? I guess we can start with Dr. Saavedra.
Maybe, can I jump in and say if I could, because I am going to have to jump off now pretty soon. My apologies, to be able to start the next round. I was saying it sort of from a very personal point of view. I think it's important, again, for us to feel very, very uncomfortable. It isn't acceptable that we all get vaccinated in the United States, and we can talk about it in very commonplace now. It's unusual to be in a gathering of people over the age of 50 and to have them not vaccinated. We should feel super uncomfortable about that. There are countries in the North, like Canada, where and I'm Canadian, so I can at least criticize my own country. I think how they got it so wrong right now is just shocking to me. But they don't have access. And then every low and middle income country around the world. Now, I have huge faith in COVAX and what COVAX can offer. But again, I think one thing we have to ask is, in countries where national leadership has failed to get it right, is it possible for subnational leaders, governors, to be able to get access to vaccines for their populations? This is going to generate more inequity, but at the same time, more access. And so I think we have to start to ask those very hard questions about disaggregating demand.
Thank you very much. Dr. Saavedra?
Yes, I think this inequity, as Dr. Knaul also mentioned, that the case of Canada, is a global issue. It's not just like one country or another country. Of course, there are some countries doing a lot worse than others, but it's also a fact that some countries are hoarding in keeping the vaccines for themselves and not authorizing the exports of that vaccines, especially the US. I mean, all the production of vaccines in the US is for the US. And like, for example, Mexico are getting the first vaccine. They got it from Pfizer. Yes, but not from Pfizer in the US, but from Pfizer in Belgium. And now some countries, even if they have the money, especially the middle income countries, even if they have the money, there is not enough production of vaccines. So they need to rely on alternative vaccines, mainly the ones coming from China and Russia. I'm not criticizing them. I think they need to vaccinate their own population. So the only access they have right now is to Chinese vaccines, Russian vaccines, but not to the leading ones being used in developed countries. Even when they have some questions and not releasing vaccines like the Johnson & Johnson or the AstraZeneca, which have like really, until now, really little negative impact, and that's why they are having on the standby. But at the same time, they don't authorize to export those vaccines, even if they are not vaccinating right now. So it's a situation, a very complex situation, and there is no international body that can prevent this thing. WHO, PAHO, they don't have the mandate to stop this from happening. Even if it is a major public health concern, they can do nothing because the way they have been structured, funded, and the mandate they have, they cannot do something. So it's an issue of the heads of state. They need to convene something really urgent, like probably an urgent meeting of the UN Security Council, because the consequences of a pandemic is like a world war. I mean, the numbers of deaths globally are similar to what were happening on a yearly basis during World War II. Of course, this is just 1 year. World War II lasted several years. I'm not saying the same numbers, but similar ones. So, well, I'll leave it there.
Thank you. So I'll just respond quickly and then turn it back to you to close. But, I'm reminded of what Dr. Deborah Birx, who was the White House coronavirus coordinator, said during a recent interview, controversial interview, that, in many respects, in the United States, for example, the first wave of COVID-19 was, and the response to it was somewhat understandable. But the second, third, and now the fourth wave is really a result of public policy decisions made by people who are elected and hired to represent us and look out for our well-being. And so with respect to vaccine equity, I think civil society should be very clear in their expectations that human rights trump intellectual property rights when we come to pandemics of this nature. That was true with HIV, it's true with TB, but it's certainly something that we need to continue to speak to today and infuse some humanism into the public policy and financial decisions that are being made by a select few people, including folks who have monopoly on public health. And then I'd also mention, of course, COVAX is an institution or an initiative that I fully support, but we cannot look to COVAX as the solution to the slow rate of vaccination. In fact, as it's constructed, we will never get to the vaccination rates that we need in order to achieve some level of control over COVID-19. And so it's absolutely critical that as we speak to funding COVAX, as we speak to addressing the issue of research and development and manufacturing capacity in other regions of the world, that we also speak very clearly about the need for a people's vaccine. And again, state clearly that our lives are worth more than dollars, pesos, whatever currency, because otherwise I fear that we will find ourselves here again in an emerging pandemic. With that, my thanks again to you, Jorge, and to Felicia, and I turn back to you. You are on mute.
Sorry. So thank you very much, Jose. Of course, to IAPAC, your team that were involved on this, to the Institute of Advanced Study of the Americas from the University of Miami, and of course to the people involved from AHF on multiple levels. There were a lot of them involved, especially the ones from Latin America. We have another closing session, but in Spanish, that is coming, so we will address most of the things that happened during those panels there. So, well, thank you very much to the audience, to the ones who are watching us through this platform or through other platforms like Facebook and some other platforms. Thank you very much to all of you, and hope to see you next time in a different venue. Thank you.
Thanks to all as well. Bye-bye.
Adios.
Bye-bye.